Hello friends, welcome to my YouTube channel TNC Updates, Toxicology and Critical Care. Before we start today's video, let me issue a disclaimer. The following videos touch various important topics of critical care medicine and toxicology. The videos are not exhaustive account of the disease conditions discussed. The videos derive their content from various standard textbooks of medicine, critical care, toxicology. But as per the guidelines change rapidly, as per the new level of evidence, the viewers are strictly advised to follow the discretion and advice of treating specialist. Today's topic is very interesting. I have chosen this topic because of demand from various people ranging from laymen to paramedical staff to doctors. Today's topic is approach to nutritional sport. This will benefit the paramedical staff, the doctors, and even the laymen if they listen to the videos. There will be something for everyone in this video. So, approach to nutritional sport. Nutrition is such a topic which is of interest to everyone. So, let us talk about nutritional sport with emphasis on critical care patients. So, changing scenario. Nutritional support for critically ill patients is no more a sportive therapy alone and is considered an active therapeutic intervention. The present classification of malnutrition encompasses both undernutrition and overnutrition, obesity. So, even obese people are malnourished. Previously, most critically ill patients were infused with parenteral nutrition at the onset, till the initial critical phase was resolved. But the current guidelines emphasize more on enteral nutrition even in the early phase of critical illness. Though partial parenteral nutrition is used as an additional supplement when the required caloric target cannot be met through enteral nutrition. So there's something called nutritional syndrome. So malnourished people can be obese or undernourished, undernutrition. Obesity, so there will be a lot of adipose tissue, fats, but there will be sarcopenia. There will be lack of muscle tissue. So muscle tissue means more of healthy part. So more of fat is unhealthy and goes towards malnutrition. So more of fat as compared to muscles, so that leads to metabolic syndrome. And what is more common in India? That is undernutrition, macro and micronutrient deficiency. So this can be further divided into two broad broad parts. One is related with chronic disease malnutrition and one is related with acute disease malnutrition. Chronic disease can be simple starvation, anorexia, malabsorption, and socioeconomic starvation. So it is a prolonged one. And cachexia, there will be loss of uh, body muscles and everything. People will become underweight. So that is over a prolonged period. But when someone is struck with some acute disease, so that is acute disease malnutrition. So we have hypercatabolic patients, post-operative, post-trauma, or mechanical obstruction of enteral feed. There is acute starvation to the body. So we have acute disease malnutrition. Physiological impact of malnutrition in critically ill patients. What is SMS? Simple marasmic starvation. What happens when the body is suddenly stopped of the important nutrients? Simple starvation, also termed as simple marasmic starvation, SMS, results from partial or total cessation of caloric intake in otherwise healthy individuals and is commonly associated with anorexia nervosa or malabsorption. However, this does not usually result in any life threatening complication as body is able to provide adequate fuel to vital organs by means of glycogenolysis and lipolysis in cases of short-term starvation, that is less than 48 hours. With prolonged starvation, that is more than 72 hours with depleted glycogen levels, since fatty acids cannot be converted to glucose, essential glucose is now derived from gluconeogenesis. The structural body proteins break down to provide amino acids as a substrate for gluconeogenesis. But soon the process of protein breakdown is halted by adaptive process whereby brain uses ketones for its metabolic fuel and the lipid stores supply the basal metabolic requirements for the body. It is only when the fat stores are depleted does further protein breakdown and gluconeogenesis become significant. So this is very important. When protein breakdown starts and even the fat stores are depleted, so that is where the stress takes over the body. So what is stress starvation? In contrast to simple starvation, stress starvation in hypercatabolic critically ill patients who have reduced ability to utilize fat as an energy source results in skeletal muscle becoming a major source of fuel, and this leads to marked wasting of lean body mass within a few days. So body starts consuming its own muscles, its own proteins for energy. It doesn't utilize fat as a source of energy as happens in simple marasmic starvation. So the difference between SMS and stress starvation is that is in simple marasmic starvation, just like as in fasting, where we have lipids as the main source of energy. In acute stress like in burns patients, in post-operative or in polytrauma patients, there the body doesn't utilize fats. It starts consuming its own muscles, own proteins. So this is called stress starvation. It is seen in major post-operative states, as I already told, severe infections, sepsis, and its sequelae. It is also called hypoalbuminemic malnutrition. So albumin levels goes down. The catabolic state is also responsible for hyperglycemia and insulin resistance. So in these patients you will have blood sugars going up. Although the patient is not diabetic, you will have high blood sugar because of, just say in head injury patients, you will have high blood sugars. So they are in hypercatabolic states. So let us summarize physiological impact of starvation versus stress. Starvation I means SMS, simple marasmic starvation. Catabolism is high, but in stress starvation it is too high. Glycogenolysis, it's high, but it is too high here. Gluconeogenesis, high, but it's too high here. Lipolysis and ketosis is too high in simple marasmic starvation. It's a bit less in stress starvation, although it's there. Energy expenditure, it's very much there on the stress side. Serum albumin will goes down in stress starvation. Urine urea nitrogen will get increased. So body is losing proteins both ways. It is losing proteins through kidneys. It is losing proteins because of body utilizing its own protein for energy. Nitrogen balance, this is very important. We will be talking about it in detail later on. So it is strongly negative in stress starvation. Extracellular water markedly increased in stress starvation. So these people will be edematous. In disease states, anorexia, nervosa, malabsorption, and where you see this severe inflammation, sepsis, burns, head injury patients. So let's depict in form of a flow chart increased inflammatory response and consequences. Increased cytokines, increased vascular permeability, extravasation of fluids and electrolytes, hypoalbuminemia. So this is both ways. Hypoalbuminemia will lead to more extravasation of fluids and electrolytes. Both of this will result in my patient is edematous. He will be having pleural effusion, so he is having pulmonary edema, and BP will go down. Hemodynamic instability will set in more rapidly in Stress starvation. So what are the indication of nutritional sport? Hypercatabolic patients with negative nitrogen balance and those with inability to take enteral or oral feeds remain the main indications in clinical practice for nutritional support in ICU. Planning a prescription for nutritional support, the 6 R's. So you can remember it. What is the reason you want to start the nutritional support? The reason, what is the requirement, what are the restrictions, route, rate, and responsibility. Reason, as we already talked, whether you are dealing with simple starvation or you are dealing with stress starvation. Inability to take oral feeds, inability to feed by enteral route. What are the requirements? Total calorie protein requirements, we will learn how to calculate them. Individualized allocation of substrates, there will be specific diseases, we will be individualizing, we will be talking about it, disease related requirements. And restrictions, caloric or specific substrates, electrolyte restrictions, fluid restrictions, restrictions due to pre-existing comorbidities. What is the route of delivery, where oral, enteral, and parenteral, we will be talking in detail. Rate of delivery, speed of achieving target calories within 2 to 3 days or begin with trophic feeds, we will be talking in detail. Speed of fluid volume delivery, risk of refeeding syndrome, responsibility. This is the most important. So, responsibility, there has to be someone who puts in the notes, takes the responsibility, mandatory to monitor patients on a regular basis. Assessment of malnutrition. Measurements like body mass index, Harris-Benedict equation, anthropometry measurements may not be appropriate in critical care settings. Indirect calorimetry is considered the gold standard to determine the energy expenditure. It is a method which estimates substrate utilization and energy expenditure using gas exchange measurements, carbon dioxide and oxygen. SGA, Subjective Global Assessment, is a comprehensive nutritional assessment mode described in 1980s. It has been validated and commonly used by most ICUs and includes history of pre-existing malnutrition and also incorporates the metabolic stress or disease component and physical examination. So this is something practical. SGA, or the Subjective Global Assessment. History of pre-existing malnutrition, history of estimated weight loss, time since last normal feed, cause of malnutrition. You have to distinguish whether it is stress or simple marasmic malnutrition. Functional loss, physical examination. You have to do the physical examination very comprehensively. Muscle wasting, body composition, edema. You have to see the sacral part, whether the patient is having edema there. So, signs of micronutrient and vitamin deficiency. You have to see the eyes, the nails, everywhere, skin, vitamin deficiency, signs of organ dysfunction. So you will be finding various organ dysfunctions, mainly liver and kidney. There are different signs and symptoms. So have a keen eye to observe the various signs. Stress level. Estimation of stress level according to severity of disease or hypercatabolic state. Calculation of nitrogen balance. We will be talking in detail. Clinician's perception. This is very important. Is the patient at increased risk without nutritional support? Does the nutrition have effect on organ functions? What is the anticipated time delay before the patient can resume normal feed? So nitrogen balance calculation. The overall metabolism of protein in the body is summarized by nitrogen balance. This represents the difference between nitrogen intake and nitrogen output. So, if I to summarize, nitrogen balance is equal to nitrogen intake minus nitrogen output. Where will be the output? In urine, in feces, and through skin in the form of sweat. So urine, feces, and sweat are output, and intake is mainly your dietary intake. So that is a very simple equation. nitrogen balance is intake minus output. So for every 6.25 gram of protein consumed, 1 gram of nitrogen is available to the body. So if I have to change this equation, nitrogen balance is actually equal to protein intake we know, just divide it by 6.25. So that will give us nitrogen intake minus urinary urea nitrogen plus 4. So this is the practical formula to calculate nitrogen balance in our patients. So why 4? Why it has been added here? It is added to urinary nitrogen to account for non-urea nitrogen losses. So visceral protein levels plus versus nitrogen balance. Visceral protein levels like serum albumin is useful in predicting surgical morbidity and mortality and long-term monitoring of nutritional status, but is not useful in assessment of nutritional status in complicated critically ill patients. Transferrin levels are influenced by the same complications commonly seen in most critically ill patients, such as dehydration or sudden volume expansion, hepatic failure, enteritis, renal dysfunction. Hence, both albumin and transferrin don't correctly reflect the nutritional status in critically ill patients, and neither are they prognostic indicators in predicting morbidity or mortality. Nitrogen balance is one nutritional parameter most commonly associated with patient outcome in those who are critically ill. Determining the nitrogen balance is useful to determine the degree of catabolism and accordingly prescribe nutritional support to keep the patient in a positive nitrogen balance. However, this may not be a realistic goal as protein breakdown continuously exceeds protein synthesis in all severely hypercatabolic patients. So how do I calculate that my patient requires how much calories? So if we daily energy requirements are usually calculated as per various equations. So this we have been taught starting from first year MBBS. Though hypercatabolic patients will require modification of Harris-Benedict equation with corrective stress factors. So you will always forget these equations. It's very difficult to remember. But just for academic and theoretical purpose, I have just elaborated. It takes into account weight, height, and age. So different equations for men and women. Men have more calorie requirements, and we have corrective stress factors that whatever comes from this equation, you have to multiply by 1.3, 1.5, and maybe 2. So this is according to the stress factors, sepsis or major surgery, severe sepsis, and something like extensive burns. But you won't remember these equations when you encounter the patient. So to simplify matters, one can calculate caloric needs ranging from 25 to 35 kilocalories per kg per day according to appropriate stress level. So stress level: unstressed, mild, moderate, severe, and burns. What is the protein requirements? So you will require, a normal person will require 1 gram per kg per day. Mild stress, it increases, and it increases further as per the severity. So a burns patient and a severe stress level can require as high as 2 grams per kg per day. So even in people who indulge in high intensity sports, they also will require even up to 3 grams, 2.5 to 3 gram per kg per day. And if you see energy requirements in a normal person, 25 kilocalories in a normal unstressed state, or even in simple marasmic, you will go for this levels only: proteins and energy, 25 kilocals per kg per day, and then you will increase by 5 with increasing incremental stress levels. And for burns, it is 25 kilocalories per kg per day plus 20 kilocalorie per percent body surface of burns. So if it is 50% burns, So 50 multiplied by 20, 1000 kilocalorie will be extra requirement. The current practice is to avoid overfeeding most critically ill patients and to restrict their caloric intake to 1500 kilocalories per day. This is contrary to earlier thinking where hypercatabolic patients often received 2000 to 3000 kilocalories per day or at times even more. However, in exceptional cases as in extensive burns, polytrauma, sepsis, higher energy requirements may be justified and certain dedicated equations as above may be used. The correct proportion. The major substrates contributing to caloric intake are carbohydrates, proteins, fats in an approximate proportion of 50%, 20%, and 30% respectively. Thus, in order to achieve a total caloric intake of say 25 kilocalorie per kg per day with increments of stress levels, one may have to give how much carbohydrates? 2 to 4 grams per kg per day of carbohydrates, 1 to 2 grams per kg per day of proteins, and 2 grams per kg per day of fats. So this you have to calculate. You will know the total calorie intake, and that total calorie intake you have to divide into the right proportion between these three major components of our diet. So you have to divide such as 50%, 20%, and 30%. Enteral nutrition is the preferred route of delivery and should be commenced at the earliest opportune time, best within 24 to 48 hours, provided there are no contraindications. It should be continued throughout the catabolic phase, regardless of food intake tolerated, and this is particularly important as it is responsible for maintaining gut integrity and preventing translocation of bacteria. Main contraindications will include intestinal obstruction, ileus, gastric stasis, severe diarrheas, GIT bleeds, or any complications that hinder achieving the nutritional goal. Routes: nasogastric tubes, jejunal tubes, percutaneous endoscopic gastrostomy. Nasogastric tubes are the Nasogastric tubes are the most common provided the stomach is functioning and gastric motility is adequate, confirmed by aspirating the tube and checking for gastric residue. On an average, a patient should tolerate a delivery of at least 1500 ml of feeds per day. If, however, the stomach is not functional, nasojejunal tubes can be done using a special tube as a blind procedure at the bedside. Difficult cases may require endoscopic and radiological assistance. The point to be noted is that the small intestine doesn't tolerate intermittent feeding as stomach. A continuous delivery of nutrients through a feeding pump may be necessary if you are into the small intestine. Feeding tubes can also be inserted directly into the stomach surgically, gastrostomy, or less invasively by percutaneous endoscopic gastrostomy. It can be extended to jejunum feeding systems, then it will become PEG-J. Jejunostomy is another procedure which will require open surgery. So choice of feed. Exclusive homemade blenderized diets or in combination with commercial feeds are still preferred by many doctors as they are less expensive. Though blenderized diets are relatively safe and have certain nutritional benefits, they may have serious disadvantage as they cannot ensure full caloric and protein needs of the patients. Strict vegetarians are deprived of sufficient proteins and may fail to achieve the positive nitrogen balance in the hypercatabolic phase. In patients with lesser injuries, such homemade feeds may suffice. Commercial feeds available in the market have densities ranging from 1 kilocalorie per ml to 2 kilocalorie per ml with protein content of 35 gram per liter as in standard formula to high protein formulas even providing 60 to 70 grams per liter. Feeds providing 2 calories per ml are useful when fluid restriction is a priority. but being hyperosmolar, these can sometimes cause diarrhea, though the risk is very small. Very important point to note is that feeding formula are not solely responsible for diarrhea. So it's very common that whenever patient starts having diarrhea, you straightway stop the feeding formulas, the various powders containing. So they are not the sole they are not solely responsible for diarrhea, but certain liquid drug preparations delivered through the feeding tubes can be extremely hyperosmolar, and some preparations may contain sorbitol that may act as laxative. Thus, these should be stopped first and not the feeds. This is being re-stressed again and again because enteral nutrition is very important. So they should be the last ones to be stopped. Never stop the enteral nutrition without being certain that they are the responsible for something like diarrhea. So diarrhea checklist you should have. The most important cause of diarrhea in ICUs in hospitals can be inappropriate use of antibiotics. Laxatives are sometimes continuing, prokinetics are sometimes continuing with the especially the antacids, the proton inhibitors. Pantoprazole comes with combination of domperidons and all that. So you sometimes miss that and instead straightway stop these. Infection can be another cause, contamination of food and feeding system. You must look if you are dependent upon your kitchen to supply the feeds to your patients. So you have to see the kitchen. The kitchen should be very hygienic. There should be no contamination of food. So there has to be regular check on the kitchen, hospital kitchen, which supplies the food to the patients. Allergy, intolerance to certain foods. You have to take the history from the patient. Rectal examination for so patient has not passed stool for 4 or 5 days and suddenly you are saying the sister is saying that she is having a diarrhea. So it is actually fecal impaction and overflow diarrhea. It's not of concern, so it will be subsiding itself. So sometimes reduce the rate. Don't immediately stop. Hypoalbuminemia can be a cause of diarrhea. So you have to correct that. If nothing else, hypoalbuminemia can be pinpointed. Osmolality. Shift to isoosmolar feeds. You give more osmolarity. So we will be talking about various feeding formulas and how to see the osmolarity I will be telling. So fluid intake, glucose polymer, medium chain triglycerides we will be talking in detail. If you don't find any cause, go for a colonoscopy. So let's come to the commercial polymeric feeds. A very wide spectrum of things available in the market and sometimes it's confusing. So let's make them very simple. The large array of feeding formula available in the market can be confusing. However, there is no convincing evidence that one is superior to the other except in very specific conditions. Hence, it will be best to use less expensive and standard polymeric formula tailored appropriately to patients' caloric and protein requirements. Semi-elemental formulas are available in the market containing small peptides or individual amino acids more readily absorbed than intact proteins and also promote water reabsorption in the intestines, thus avoiding diarrhea. They are usually expensive and prescribed in patients with impaired digestive and absorptive capacities like malabsorption syndrome, short gut syndrome, in patients with pancreatitis, decreasing the exocrine stimulation. So you have to just uh, give rest to the pancreas, and we have a feed which is easily digestible. A standard polymeric formula which is given to all the patients. The osmolarity of this formula should be 1 kilocalorie per ml is infused initially at a rate of 50 ml per hour for the first 3 hours and checked for residual volume. If tolerated well, it may be continued at the same rate or increased by 10 to 15 ml per hour every 8 hours until the target caloric goal is achieved. But one should avoid increasing to more than 100 ml per hour. These rates are for those patients who are only on these polymeric formulas, only on this commercial polymeric. What is happening mostly in the ICUs is that you are getting the feeds from the kitchen and you are mixing these formulas to the kitchen feeds. So when the patient is dependent only on the scientific polymeric formula, these rates have to be applied. In kitchen feeds, when you are mixing more of as a supplement, you can be a bit more relaxed. Elemental formula should be commenced at a much slower rate and be progressively increased but very slow. So it should be at half the rates of this. If it's 50 ml per hour for the first 3 years, it is 25 ml. So it's more slow. So if we see in a standard polymeric commercial formula, we have protein content of around 40 to 80 grams per liter. And where the protein comes from, it is caseinate, soy protein isolate, D-lactose lactalbumin, beef, egg albumin, egg white, low-fat milk. So you have those green and brown colors on your powder packets indicating vegetarian if it's from the milk. And so you can have protein from various sources. You can have from beef, you can have from egg albumin. So these animal sources have very high bioavailability. So they have been chosen in some of the formulas. Carbohydrate content, it will be almost double of this. So 100 to 200 grams per liter because the proportion is almost 50% you have to give. 50%, 20 and 30%. Source of carbohydrate, maltodextrin, glucose polymers, sucrose, glucose, fructose. Fat contents 20 to 90 grams per liter. Source of fats can be various vegetable sources like soybean oil, coconut oil. So long chain triglycerides from soybean, coconut will be supplying middle chain triglycerides, corn oil, canola oil, sunflowers and safflower oils. Caloric density overall should be 1 to 2 calories per ml. So this is a normal powder bag which is available in ICUs. So mostly you have suppose 400 grams bag is there. So you will be having measurements per 100 grams and you will be having measurements per serving 24 grams. So you will be having proteins, energy and carbohydrates as the first three listings. So energy will be per serving also. In some of the bags it will be per 100 ml of the prepared preparation also. I will be showing that also. So we have saturated fats, monounsaturated. We'll be talking in detail about fats, saturated, MUFA and PUFA. So trans fats. So we have then various nutrients, micronutrients in the form of various vitamins, and we have various micronutrients in the form of minerals. So we have also some specific cases like diabetic patients. We will be having different types of ingredients which will have be having a effect on glycemic index. So in this case, just see this. If we see the energy part, we have per 100 ml 94. So in diabetic patient, you see this over here per 100 ml prepared feed. There is in per 100 ml. So energy is 94 kilocalories per 100 ml. So it is almost equivalent to what we specified in the slide, 1 kilocalorie per ml. So proteins, energy, carbohydrates per 100 ml we can have. So how you get this concentration, especially in those patients who are only on these polymer formulas? So for that, method of preparation is very important. You have to go by the exact measurements, how many scoops to be added in the amount of water. So the method of preparation is always specified on the uh, paper, on the powder container. So for example, it is written 190 ml water and 6 leveled scoops which equals to 50 gram will give this concentration. So if you prepare a concentration which is more, so you will get hyperosmolar, then the patient will have diarrhea if he is only on these polymeric formulas. If the patient is on kitchen feed plus this as a supplement, he will not have that much effect. So this is one of the elemental, semi-elemental feeds. So it is a peptide-based diet. So for example, if I am having a pancreatitis patient in my ICU, I will be using something like this. So it is a peptide-based diet for the dietary management of individuals with impaired GIT functions, and it contains hydrolyzed whey proteins. So 70% will be as MCTs. So it's a peptide based diet, and it is for various very important clinical conditions where nutrition is such an important thing and you are not able to give. So it helps very much in acute pancreatitis and other syndromes like short gut syndrome and extra, etc. So this can be same way we will have the composition in this. So in this we will have more of MCTs as 70% specified here. Why enteral nutrition? The main advantage of enteral nutrition in critically ill patients other than meeting of nutrient requirement is to maintain a normal intestinal integrity. Even small amounts of feed should be started at the earliest as these help to maintain a normal intestinal barrier and immunological function during the severe phase of systemic inflammatory response. So your gut is also your immune system. A leaky gut is a signal of malfunction of your immunity. Current guidelines support trophic feeds beginning with an initial caloric intake of 10 to 20 kilocalories per hour, that is 250 to 500 kilocalories per day. So even if you are not able to start a proper caloric target meeting feed, you have to start with trophic feeds. Actually, the concept of trophic feeds originated in premature infants, where they started with smaller feeds to stimulate the development of intestinal mucosa in premature infants. So, even in stressed patients, in ICU patients, in critical patients, start with trophic feeds at least to start something called enteral nutrition, because it is also the immunological function which will overall help in the recovery of the patients, and later on you can increase the caloric intake towards your target as the patient tolerates. Slowly the rate of delivery is increased over a 5 to 7 day period. Only when we fail to achieve our caloric and protein targets, which can be unacceptable in hypercatabolic, critically ill patients, supplemental parenteral nutrition can be required to achieve the protein caloric target. So you have to wait for 5 to 7 days. You can have this liberty of 5 to 7 days till you start with the slow trophic feeds. If you are then also not, you at 5 days of period you are still not able to meet your target, then you can supplement it with parenteral nutrition. Standard instructions for enteral nutrition: physician should place the tube. Actually, the practice is mostly that nursing staff places, so it should be under the supervision of at least the physician. Elevate head end of the bed by 30 degree, more than 30 degree during feeding. Aspirate if symptomatic distension. If aspirate is less than 150 ml, return the aspirate and continue feeding. If aspirate is more than 150 but less than 500 ml, reduce feeding rate, notify physician, consider prokinetics. If aspirate is more than 500 ml, hold feeding. Notify physician, assess the cause, may consider use of prokinetics or nasojejunal feeding or partial parenteral nutrition, or reduce feeding rate by 50% depending on the residual volume. Irrigate tube 4 hourly with 40 ml water and 12 hourly with 10 ml soda bicarb and after each medication. Enteral pump to be used for continuous feeding, and don't let formula hang for longer than 8 hours. Administration said that is feeding tube bags to be changed every 24 hours. Blood glucose test to be done every 6 hours. Weigh the patient on alternate days. Renal and liver function tests Tests check once a week or as required for the underlying disease severity. Parenteral nutrition. Parenteral nutrition is indicated in a selective group of patients who have a total or partial mechanical obstruction or a non-functioning alimentary tract. Also needed when enteral nutrition alone is unable to meet the nutritional needs. In general, the composition of parenteral nutrition is amino acids as protein, source and glucose with lipids to provide non-protein energy. Trace elements, electrolytes are often incorporated in the solutions but may not be sufficient to cover the daily requirements of the critically ill patients. Hence, vitamins and trace elements may have to be supplemented. We will see some of the preparations available in the market. How to proceed in parenteral nutrition? Preferable to commence parenteral nutrition after the patient has been resuscitated from shock and is reasonably stable. Also very imperative to correct any gross abnormalities of ABG, fluid electrolyte balance, and blood sugar levels before starting parenteral nutrition. The initial dose glucose should not exceed 200 grams per day to avoid hyperglycemia, and in susceptible patients with pre-existing and prolonged starvation, both glucose and caloric intake should be restricted in the first few days to avoid refeeding syndrome. So refeeding syndrome is actually a life-threatening conditions. So it is mostly seen in those patients who have been not taking enteral feeding or very insufficient enteral feeding for more than at least 10 days. So it is mostly when you don't take the enteral feed, hypophosphatemia develops. So hypophosphatemia is the starting event for various other electrolyte and metabolic events which occur in refeeding syndrome, hypokalemia, hypomagnesemia. So all those shifts intracellular, extracellular occur which can result in life-threatening arrhythmias which can be very much distressing. Full requirement of amino acids 1 to 1.5 gram per kg protein per day can be started from the first day provided there are no specific contrast. So glucose you have to start slow, amino acids and lipids you don't have that contradiction. So you can start as per the full requirement. Lipids are by and large safe and well tolerated by most critically ill patients. However, serum triglycerides should be monitored. Hypertriglyceridemia occurs when lipid infusion far exceeds plasma triglyceride clearance, which can be affected in patients with renal failure and in those receiving excessive glucose, which stimulates lipogenesis. Soya based lipid emulsions are best avoided during the first week of parenteral nutrition. So this is commonly available in 20% weight by volume fat emulsion with medium and long chain triglycerides. So when you ask for this, they will give each 100 ml just. And Terrell also has that all that ingredients same is the parenteral. So parenteral you have various in soybean oil, medium chain triglycerides. So there you have coconut oil and everything like so the same things. Egg lecithin. Egg lecithin is something which is obtained from egg yellow part, yolk part. So it is a phospholipid part. So egg yellow part, just as a sideline, I will tell you, it has got very important nutrients: biotin, niacin, vitamin B, selenium. So egg lecithin is emulsifier. It is a stabilizer. So it is mostly added to these lipid emulsions. So osmolarity and energy per liter is given. So if you give 250 ml, mostly it is available in 200 ml and 250 ml. So per liter they have given the calories. You can calculate from it how much calories 200 or 250 ml will contain. So what I mean is you have to calculate the total calories also after all in the end. And this is osmolarity. So this is the amino acids which are mostly available as 10% weight by volume. So various amino acids are there, isoleucine, leucine, and so all amino acids can be there. Plus they are supplemented with various micronutrients. So sodium, potassium, all these have been given. So you will again get energy content. So this is 400 kilocalories per liter. See, lipids had a much more, because the caloric value of lipids is 9 kilocalorie per gram, and this is on the 4 kilocalorie per gram. So 400 kilocalories per liter. So this is a 500 ml bottle, and it will have 200 kilocalories. So you have to calculate the total calories in the end. So for specific patients, like my patient is having hepatic encephalopathy, so I want something called branched chain amino acids, which have been shown in various studies to help in hepatic encephalopathy. So patient can be given amino acids which are mostly branched chain only have been uh, put as ingredients out here. So we have isoleucine, leucine, phenylalanine, methionine, threonine, tryptophan, valine, arginine, histidine. So that is also available. So complications of parenteral nutrition, there can be many complications. Mechanical and technical complications, so related to central lines. So if you are having patient who has having fever which is not going away, always suspect various lines, and central line is always the first suspect. Catheter related bloodstream infections, metabolic complications, unexplained fever in a patient with central venous catheter must be attributed to the central line until proven otherwise. Final confirmation of catheter related bloodstream infection is isolation of the same organism from the central line and percutaneous collection. So mostly Staph aureus and Candida, etc. Regular dressings, use of single lumen catheters, dedicated central lines, and using fresh sites for patients needing replacement of infected catheters will help in reducing the incidence of CRBSI. So mostly I see in ICUs, when the patients are prolonged, what they do is through the guide wire they put another central line. No, that is a wrong practice. If you have to change the central line, you have to change the site. You have to change to a new site and try to put subclavian instead of internal jugular and femoral. And always try to change dressings, have a protocol in your ICU, and always send the central line you are taking out for a culture sensitivity, so that you will always know the flora of your ICU. Blood glucose levels, why so important? The most common metabolic complication is hyperglycemia. Maintaining a well controlled glucose level is important, but the earlier practice of very tight blood sugar below 110 is not at all encouraged by the current guidelines because of the risk of hypoglycemia, which can be more detrimental with dire consequences, as it can attenuate the humoral and clinical response, resulting in autonomic dysfunction. Something called relative hypoglycemia. This concept suggests that the counter-regulatory release of epinephrine, norepinephrine, and cortisol, preventing autonomic dysfunction, occurs at a higher glucose level of 120 to 150 milligram percent in poorly controlled diabetics. So, if a patient is always having a blood sugar of 200 plus, his hypoglycemia will not occur at 120 or 100. His hypoglycemia can occur even at 130. So that is meant by relative hypoglycemia. So, uh, in such patients, you have to have a line which is much higher. You can't have a line of 110 as the standard कि below इससे होगा तो hypoglycemia होगा. So based on this concept, the hyperglycemia at levels of doesn't harm critically ill patients. So you have to maintain in this range 150 to 180 or 120 to 150 in perhaps burns patients. So our tolerance has increased much better than the previous levels which were indicated in studies. Current guidelines consider a sliding scale or correction algorithm outdated, as it tries to correct the blood sugar of previous few hours rather than the next few hours. For critically ill patients, continuous insulin infusions should be the first choice to maintain the desired levels. Hepatic dysfunction with TPN. Serious hepatic dysfunction with TPN is rare in adults. Mildly elevated levels of liver enzymes usually return to normal and don't warrant discontinuation of TPN. Protein intake will have to be reduced to 0.5 grams per kg per day in patients with encephalopathy. But in severely hypercatabolic patients requiring higher protein intake, branched chain amino acids can be used. So, how do you monitor the patients on nutritional support? So, frequent assessment, parenteral or enteral. You have to assess whether calorie intake should be increased, decreased, protein. So, from when the patient is recovering, he will change from catabolic phase to rehabilitation phase. So, his requirements can change. So, both for enteral and parenteral, you have to have this parameter. Then tolerance to feeds in enteral nutrition, regular measurements of resting gastric residue. Parenteral nutrition, strict maintenance of fluid balance to avoid overload. Metabolic derangements, both for enteral and parenteral, you will have various measurements: sugar, electrolytes, creatinine, calcium, magnesium, liver function, serum albumins, pre-albumins. Catheter with tubes. So in enteral, what is there? There is a Ryle's tube, feeding tubes. In parenteral, your central lines are there. Nitrogen balance is again common to both enteral and parenteral. So you have to calculate the nitrogen balance and you have to see whether adequate requirements are being met. So, trophic feeds and autophagia. Trophic feeds, permissive hypocaloric feeds, have been advocated in many guidelines. The reason behind is the concept of autophagia, which is supposed to have a protective mechanism for cells which are under stress or inflammation and works during the period of fast and is suppressed during forced feeding. So, in Indian culture, we have a concept called fasting at least 1 day per week. So, this concept has been now supported by scientific evidence. Why? Because there is something called trophic feeds and autophagia. इट सेज कि जब आप फास्ट करते हैं तो आपकी बॉडी रिकवर करती है. कैसे रिकवर करती है? बिकॉज of this process. This process of autophagia is essentially a process used by eukaryotic cells to recycle old or damaged cellular components in response to stress and cellular damage, and was first conceived by Nobel laureate. He was a Japanese scientist and he got a Nobel Prize for this, Yoshinori Osumi. So science came to know about it much later. Our culture is practicing much earlier this concept. However, does this apply to critical patients in ICU? However, one can counter by questioning whether lean body mass is preserved during peak catabolic phase by a starvation diet of hypocaloric feeds of less than 500 kilocalories per day, or by delivering adequate calories and maintaining a positive nitrogen balance. The present guideline states all critically ill patients, such as those with extensive burns, severe pancreatitis, polytrauma, and who have a high Nutrix score. Nutrix score is actually a score which is based for critically ill patients. It has various parameters like age is there, comorbidities are there, then interleukin 6 is there, then we have a time to admission. So we have various parameters, and if the patient scores very heavily on that Nutrix score, then the patient is more ill. So he should not receive these feeds. He should have proper adequate feeds, should not receive trophic feeds during the hypercatabolic phase. So, disease modified nutritional support in ICU patients, mechanically ventilated patients. Avoid excess calories from glucose source as it may lead to increased carbon dioxide production and increased ventilator demands. Adequate calories and proteins. Liver failure patients, as already stated, in presence of encephalopathy, decrease protein intake with increase of branch chain amino acids. Renal dysfunction, fluid restriction. So calories compromise because of fluid restriction and lipids become an important source of energy. Monitor for electrolyte imbalance, especially hyperkalemia, hypomagnesemia. To restrict proteins in CKD patients. So in chronic kidney disease, you have low protein powders, or consider RRT in severely hypercatabolic patients and allow liberal use of fluids and electrolytes. Pancreatitis, how can we forget when we are talking of nutrition? So, determine disease severity, confirm volume resuscitation, achieve enteral excess, whether it is gastric, whether it is jejunal. Tolerance during severe necrotizing Infective pancreatitis improved mainly during jejunal feeds and changes in feeding formula. Small peptide, medium chain triglyceride, and semi elemental formulas reduce endocrine exocrine secretions. An immune modulating formula, fish oil, glutamine, arginine. Avoid probiotics. Monitor tolerance, enzyme secretion, gut mobility. Triglyceride should be less than 400. Parenteral nutrition worsens outcomes if started less than 24 hours, should be given after 5 days if enteral nutrition is less than 60% of the goals. So, enteral nutrition should be always the first choice even in pancreatitis. If we have critically ill obese patients, BMI more than 30. So respiratory risk, decreased ventilatory capacity, decreased work of breathing, hypoalbuminemia, increased risk of pulmonary edema, overfeeding, increased CO2 production causing weaning failures. Correction of malnutrition, increased protein intake, avoid high carbohydrate diets may require ventilatory support. Metabolic risk, nitrogen balance doesn't depend on energy balance. Energy expenditure is difficult to predict, overfeeding detrimental. Maintain positive nitrogen balance. In nutshell, you have to have a high protein intake. Correlate energy expenditure on ideal body weight. So ideal body weight is something which has to be used whenever the patient is on ventilator, whether it is ARDS, whether it is you are estimating tidal volume for a ventilator of ARDS patient, or whether you are estimating the calorie requirement of a patient who is very obese and in a critical condition, then also you have to calculate the requirement on the basis of not actual body weight but the ideal body weight. So ideal body weight formula is 2.2 into body mass index plus 3.5 into body mass index into height minus 1.5 meters. But this is not that much practical. You won't remember it when you are on the bedside. So a simple formula which has been very much supported by various studies is ideal body weight is 22 into H2 height into multiplied by 2, where h is equal to patient height in meters. So suppose my patient has a height of 5 feet and 5 feet or something like 1.5 meters. So 1.5 if I put in place of h, so 1.5 multiplied by 2 becomes 3, and 3 multiplied by 22 is 66. So although the actual weight of the patient may be 100 kg plus, but I will take that weight as 66 if his height is only 1.5 meters. Hypocaloric, you have to give high protein diets. So something about immunonutrition, very important. Working definition of immunonutrition can be modulation of the activities of the immune system and the consequences on the patient of the immune activation by nutrients or specific food items fed in amounts above those normally encountered in the diet. These mostly include the amino acids, glutamine, arginine, omega-3 fatty acids, nucleotides, antioxidants, vitamins, and minerals. Omega-6 and omega-3, the seesaw swing. PUFA, omega-6, omega-3 fatty acids cannot be synthesized in the body and hence are obtained from the food we eat. PUFAs, which are predominant in our normal diet today, are obtained from vegetable oils and from depot fats of mammals, and these are mainly linoleic acid, omega-6 fatty acid, but in societies whose food mainly contains deep sea fish incorporate larger quantities of alpha-linolenic acid, that is omega-3 fatty acid. Once consumed, these fatty acids are converted to larger chains of more unsaturated derivatives. Linoleic is converted to arachidonic acid and linolenic is converted to icosapentanoic and docosahexaenoic acid. So omega-3 fatty acids, linoleic acid, icosapentanoic and docosahexaenoic acid. These are very important. Both EPA, that is icosapenta, and hexa are produced in algae and plankton. So जो fish होती हैं वो इनको खाती हैं और जो fish को खाते हैं वो इसका सेवन कर लेते हैं. So both EPA, DHA are produced in algae and plankton, hence fish oils extracted from deep sea fish, herring, salmons, tuna, sardines, mackerel, which live on planktons, provide the main source of. So all these are omega-3 fatty acids for humans. Both omega-3 and 6 are important essential fatty acids for humans, and their deficiency can lead to wide array of clinical disorders. So this is important because this cannot be synthesized in the body. So you have to have a proper intake. Very important. In critically ill patients, omega 6 products are thought to be pro inflammatory mediators, whereas EPA omega 3 acts as anti inflammatory or rather less pro inflammatory, thereby making their interaction critical. Considering they both are competitive substrates, it is therefore essential to have an optimal ratio of both in critical care settings. Lipids commonly used in parenteral feeds have traditionally been based on soybean oil, which is rich in omega 6 fatty acids. Hence, adding omega 3 fatty acid as a separate lipid emulsion that is now commercially available may help in attaining a balanced ratio. Omega 3 can be given as a relatively small proportion of 10 to 20% of total lipids given, however, due to limited experience, refrain from using the product in grossly unstable patients or in patients with severe renal or liver failure and in pregnant women. Glutamine. Glutamine is considered a non-essential amino acid, but during hypercatabolic state, when skeletal muscle stores and plasma levels become depleted, it may become a conditionally essential amino acid. Its depletion can result in decreased gut integrity and immunity. IV glutamine probably improves both and hence decreases bacterial translocation. It is probably it is difficult to mix glutamine in TPN and it is more stable as dipeptides. So it doesn't come in the amino acid formulation. Addition of glutamine in entirely fed patients has not shown a. Earlier we used to have various powders also, but it has stopped because it has not shown any benefit. So the present conclusion as per the level of evidence can be summarized. There was no overall mortality benefit or reduction in length of hospital stay. There was reduction in nosocomial infection rate mainly in surgical patients who received higher than recommended dose. Had a there was a reduction in nosocomial infection rate mainly in the surgical patients, and patients who received higher than the recommended dose had a higher mortality. Arginine is a non-essential amino acid and has beneficial and deleterious effects. Arginine deficiency develops after trauma or major surgery and can impair wound healing, and arginine supplements may benefit these group of surgical patients. However, it is precursor for the synthesis of nitric oxide, which may benefit in certain specific conditions by producing vasodilatation, but it can adversely affect patients of severe sepsis, resulting in marked hypotension and hemodynamic collapse. For the above reason, and also the fact that its potent oxidizing and nitrating action may increase the gut barrier permeability, arginine is contraindicated in critically ill patients, particularly in the setting of severe sepsis. Antioxidant supplements, these include selenium, zinc, copper, vitamin B, C, and E. Selenium may have potential benefits if given in appropriate doses, though it has not shown any significant reduction in mortality. Zinc, copper, vitamins, though important for long-term nutrition support, have shown no definite benefit as supplements in nutritional support in critically ill patients, as there are no major trials conducted. Important thing to note is that trace elements can be potentially harmful in large quantities. So in COVID, a lot of zinc was being prescribed by everyone. So you have to remember zinc given in doses more than 50 mg per day may cause immunosuppression, progressive cholestasis, while copper may lead to liver damage and hemolytic anemias. So what is the current thinking? The current thinking is to avoid immunonutrition in life-threatening septic patients with Apache score of more than 20, where such radical changes in nutrients may perhaps adversely affect the outcome. Instead, it is to be used in less serious patients of sepsis or early sepsis and in surgical patients in where it may help in wound healing and reduction of infection rates. So a lot of pharma companies coming up with immunonutrition, you have to know what the facts are. So these are the facts. The 2016 guidelines of Society of Critical Care Medicine and American Society for Parenteral and Enteral Nutrition guidelines recommend that immune modulating entero formula should not be used in medical ICU, but such formula may be appropriate for surgical patients. The majority of studies have shown that immune nutrition has potential benefits for elective surgery patients, but not for critically ill medical patients. Almost all studies have shown nil benefit in terms of mortality, hospital stay, or ventilator days. Thank you so much for listening.